Good evening, everyone, and we welcome you to Season 6, Episode 7 of Doc Talks with Dr. Forrest, Tennant, and friends. We have a great show ahead of us, as usual, and we really look forward to it. Dr. Tennant, we thank you so much, and it's all yours. Take it from here. Thanks, Doc.
Thank you very much. Well, we have an interesting program here today that's going to be quite varied. I've asked Scott Guest to give us a little update on supply problems. I've asked Allison Geitness to give us an update on ivermectin and Epstein-Barr. We're going to interview an author who's written a very nice new article on arachnoiditis. And I want to start off this show with, I hope, something that's maybe even a game changer. Some of you have heard about a new drug that has been produced that is a non-opioid pain reliever. And I want to talk about it because we weren't certain where this was going to show up. The drug's name is Journavx. It's got a funny spelling. Okay. Journayx. The chemical name is suzetrigine. And anyway, this drug is not an opioid drug, but it's what they call a channel blocker. And it's been approved by the FDA for acute pain treatment. Now, it's been shown in double-blind studies to be very good, provide good pain control. And I've been watching this thing very closely. The thing I'm bringing it up to you tonight is that we do now have reports of people with both adhesive arachnoiditis and CRPS and EDS all are getting some pain relief with this drug. It certainly does work for some people. Now, this is very important because this is not an opioid drug and it's not even a controlled drug. Now, what we're learning is that physicians are willing to prescribe this drug for pain treatment because it's not controlled. And you'll hear a lot on this program about the problems with medical boards and oversight and people being watched if they take controlled drugs. But you have a lot of doctors who will prescribe something for pain as long as it's not a controlled drug. This is not a controlled drug. And we've already getting reports that there's a lot of physicians and nurse practitioners who will prescribe this drug for pain when they won't prescribe a Vicodin or an oxycodone or a fentanyl patch or a dilaudid, but they will prescribe this because it's not controlled. How good is it? Let me put it this way. We have enough reports already to know that it works for most people. Now, one of the things that you're going to run into with this, they're going to say, well, I have chronic pain. Well, you may have chronic pain, but you also have acute flares. Now, the indication on this label is for acute pain. It was really brought out by the manufacturer to deal primarily with pre and post-surgical pain because they're acute short-term times. But everybody watching this show who has pain has acute flares, and this drug would be ideal. So what I'm here tonight to do is to call on people who have pain. If you're not getting enough pain relief from your private doctor, they won't prescribe opioids or they won't prescribe enough, you need to know the name Journavx. Here it is, right here. The dose is 50 milligrams every 12 hours. That's the dosage. And you need to take this information to your physician or nurse practitioner and say you would like a therapeutic trial with this drug. Incidentally, it might surprise you, the insurance companies are much more prone to pay for this than they are a codeine or a Vicodin because it's not an opioid. And so they also seem to be far more willing to pay for this than they are opioid drugs. But at this point in time, if you are not getting enough pain relief from your private doctor or nurse practitioner, you need to call on them to consider giving you a therapeutic trial, a dozen, 2 dozen of these this new drug, and try it out for your flare pain and see how it works for you. Again, this could be a real change, but and you will find there will be a lot of doctors who will prescribe this when they won't prescribe an opioid for you. So that's an announcement that I wanted to make here tonight. Could be a game changer. We could find that this really brings a lot of pain relief to people who aren't getting it. But again, I want to summarize it by saying this. If you are not getting the pain relief that you think you should have, you should talk to your doctor or your nurse practitioner or PA about getting Journavx as a trial and see how well it's going to work, particularly for your acute flares. Now, the second thing I want to do for you is to talk about something that's a little historic, but it's also information that everybody needs to know. And to start this off, I'm going to take you back to how I got started with arachnoiditis hope. We started arachnoiditis hope back in 2017, 8 years ago. Now, why did we start arachnoiditis hope? Well, first off, in my clinic, we were taking the severe intractable palliative care pain cases, and at least half those cases were turning out to be adhesive arachnoiditis, and about half of those had Ehlers-Danlos syndrome. So the advent of Ehlers-Danlos syndrome and adhesive arachnoiditis had arrived, and there wasn't anything being done about it. At that time, in 2017, you could not find the word arachnoiditis in any medical textbook. You couldn't find anything written about it. There was nothing on the internet. In other words, there was nothing. In other words, where was a doctor to go to find out anything about this disease? There was zero, nothing. So we put together Arachnoiditis Hope, had our foundation raise some funds, and to get started. Now, we set out first off to have a mission. And our mission back then was to bring diagnosis and treatment of adhesive arachnoiditis to every community, regardless of what country or where that was on this planet. We knew that the disease was getting common enough, and we're going to talk about that in a little bit, that it needed to be known by doctors in every community on this planet. So that was our general mission statement. But our objective was to develop protocols for doctors and medical practitioners to treat this disease. And so we sort of formed what we call Operation Protocol. Now, first off, what is a protocol as opposed to a treatment or a therapy or a measure? A protocol is a process. It means that you sort of have a decision tree, if you will, in which the medical practitioner can pick one thing or another, but stays within a certain confines to achieve a certain outcome. But think of it this way, a protocol is a process. Now, a treatment usually applies one drug, one therapy, one surgery, one thing at a time. A protocol is comprehensive. It brings in a sort of a holistic scheme, if you will, to where it can include diet, exercise, therapy, a physical and mental, pharmacologic, nutritional. In other words, a protocol encompasses more than just one single thing to get the job done. And chronic disease and something's very serious like adhesive arachnoiditis or EDS or CRPS, you need a protocol because no one thing is going to get the job done. You're going to have to put together a multi-purpose drug regimen, a multi-drug program, if you will, and include other measures with the protocol. Now, early on, we had already done some research to determine that protocols for adhesive arachnoiditis, and it's also, in my opinion, for every other intractable pain disease, three basic components. And this is not new. We've had this a long time before 2017. And that is to deal with intractable pain problems, you've got to have a protocol that's got three components. One is you got to have pain relief. Number one, if you don't relieve the pain, you can't think, you can't work, you can't get out of bed, you can't take medicines, nothing works. You got to have pain control. Component number one. The second component is all intractable pain conditions are going to involve some form of inflammation, and today we know probably autoimmunity. So your second component, you're going to have to suppress or control inflammation either in the brain, the spinal cord, the peripheral nerves, the muscles, the tendons. You're going to have inflammation that's going to have to be controlled and suppressed. And then the third component is, if you want to permanently reduce pain, you've got to treat the disease and you've got to reduce the severity of the disease. And you do that by regenerating damaged or injured tissue. So regeneration of tissue is the third component. So let me report again, cover the three big general components of a protocol for an intractable pain condition. One is pain control. Number two, suppression of inflammation and autoimmunity. Number three, regeneration of damaged and injured tissue. Those are your three big components. Now, back in 2017, with a man by the name of Dr. John Valillo and I had already done some studies on intractable pain patients to confirm that it wasn't an inflammatory disease. Interestingly enough, arachnoiditis was defined as an inflammation of the arachnoid in 1873, a long time ago. And all we did was document this and realize that these three big pillars of components is where you have to be to try to deal with this disease. And so we have done that. But what I wanted to bring to your attention tonight is the first thing we tried to do back in 2017 was get some kind of a protocol just to let doctors and nurses get started. But since then, I'm pleased to say that we've been trying to develop protocols over the last 8 years with Operation Protocol. And I'm pleased to say that we've added some new protocols out there. And I'm going to read to you the ones that we now have on our website and are now available for medical practitioners. We've got the general one, treatment for adhesive arachnoiditis, but we also now have a written protocol for spinal fluid leakage. We have one for pain flares. We have emergency treatment after punctures and epidurals to prevent adhesive arachnoiditis. And we've just developed a new one on Epstein-Barr virus reactivation. Now, those 5 protocols are on our website. Now, why I want to talk to you a little more about what protocols really do mean, and something that that you should know about. Now, first off, I want to show you something here. You've probably never seen this. This is a big book. It's called Current Diagnosis and Treatment. Here's another big book called Cons Current Therapy. Now, why am I showing you these 2 books? Each year, Current Therapy and Current Diagnosis and Therapy are published for doctors. And any doctor worth their salt has one or both of these on their shelf to look up in these and treat anything. And in these, you've got hundreds of diagnoses, hundreds of diseases. But guess what? Not in these books, there is no mention of the word arachnoiditis, Ehlers-Danlos syndrome, Tarloff cyst, CRPS, reflex sympathetic dystrophy. Those terms are not even in these books. Okay, now, if they're not in these books, where is the world as a doctor or nurse practitioner going to get information on how to treat anything? Okay, that's why we've developed these protocols so the doctors and nurse practitioners have something to go on. This is also why I encourage everybody out here, when you get material about any of these diseases, take them to your doctor, give them to your doctor. Why? He's not going to get them in any organized system. Now I want to show you another book. Here is a book called Harrison's Principles of Internal Medicine. Now, what is this great big huge book? This is the medical school book. Okay. Now, if it's not in that book, it's not going to be taught in medical school. If the disease is not in current medical diagnosis and treatment, the doctors have no information about it and no guidelines on what to treat. So what that we now at least have is a way for the doctors to get some information. They don't have to like the protocols. The protocols give them some different options, but it gives them something to go on, some basis. And I think patients need to know that these protocols are available. Advocates certainly need to know they're available. And certainly you can tell your doctor about them. They're on our website. Also, we send them to anybody who wants them, but we have to give the medical people information out there. I hear gripes all the time. How come we're not teaching this stuff in medical school? How come the doctors aren't going to treat us? First off, where's the doctor going to find out something about it? If the doctor doesn't know they're on a website or they can go look it up, what are they going to do? So this idea that the medical profession doesn't want to help or what have you isn't necessarily true. They've got to have some information to do so. So I'm pleased to say that Operation Protocol has moved forward to where over time we've been able to get enough information, enough reports, enough research to give the doctors and nurse practitioners and PAs protocols that they can work off of. Now, I might want to bring a couple of other things to you that are very topical. There is not a week goes by now that our foundation does not hear about somebody who has developed symptoms after a spinal tap or an epidural, and these people are panicked. They develop severe back pain, their leg pain, their bladder may start not working. They may start the bugs crawling on their legs, the headaches, the dizziness, they can't get out of bed, they're scared to death. And those people need the emergency treatment to hopefully keep from developing adhesive arachnoiditis. And we've also learned that the Epstein-Barr virus may be attacking some of those people right after the epidurals or right after the spinal taps and may be causing part of the problem. We're not sure about that yet, but nevertheless, we do have emergency protocols for people to at least try to prevent adhesive arachnoiditis after surgery or after epidurals or spinal taps that go bad. I want to say a couple of other things about the new protocol for adhesive arachnoiditis. We have finally published in writing some alternatives to corticosteroids. A lot of doctors just don't want to use them. I think that's unfortunate, but if they don't want to, at least we have got a written alternative for them. Ketorolac is the same way. A lot of doctors just don't want to use ketorolac. They think it's too dangerous. We do have some alternatives for that drug also. But the protocols today also incorporates the diet, the exercises, and it includes the three components, the pain relief, the suppression of inflammation, and the regeneration of tissues. Now, let me also say something that I want to say that very hopeful. I like protocols for another reason. They're sort of like a business. They're sort of like an endeavor. They can be improved upon. In other words, as time goes on, you get a better drug, you get a better therapy, a better idea, a better dosage. You can modify the protocol to get better and better. And I must say, one of my great joys of my life these days is that I hear from people literally weekly who are reducing their symptoms of CRPS, Ehlers-Danlos, adhesive arachnoiditis down to where the levels of their pain and disability are such that they can really function and have a decent life. And is it possible for us to talk about cure these days? I don't know that it is. I can sure say that near cure, I think, is a good possibility. And I think as our protocols get better and better, that's how we're going to get to where we might get a near cure. Do I think cure is possible? I think it's possible with adhesive arachnoiditis if we get the right combination in the right protocols. I think it just might happen. I'm hopeful and I'm going to keep working toward that, and I hope you do too. So that's kind of where we're at the moment. I want to try to move on here right now. We have a guest today that we want to interview. We have with us Julie, I hope I'm saying her last name, Titone, and Julie is with us. She has written a wonderful article on adhesive arachnoiditis, and we want to bring her on and talk to her about this very fine thing she's written. Can we bring Julie on?
Hello.
Hi, Julie. How you doing?
I'm doing fine, and it's Julie Titone. It's a Sicilian name.
Okay.
Yeah, I'm out here in Washington State. Hello, everybody. Yeah.
Well, if you're Sicilian, I hope you've got the the blood and the lineage to take care of a few people for us.
Oh,
Others-
well, I don't know about that. I'm a more of a conciliator and I'm a question asker. My background is in journalism and nonprofit communications. And like a lot of people who get diagnosed with arachnoiditis, we're like, well, what can we do to spread the word, to spread awareness of this disease and, use whatever skills we might have to do that. So that's where I am, and that's why I felt compelled to write an article that I self-published on Substack because it was the quickest way to start getting it out there to people. But my intention, first I shared it with family and friends to really give them good information about what was going on with grandma, what was going on with Julie, what was the cause of her pain. And then to my great gratification, I shared the article with three of my physicians, my primary doc and my pain specialist and the surgeon who did the spinal fusion, which was the onset, in my case, of arachnoiditis. And they each read it and responded to me. And I found that very gratifying, and found it interesting. And, each of these people, I think their response to my situation is instructional, and it's something that many of you will recognize. My surgeon, to his credit, about 3 months out from surgery when I'm saying, hey, you reinforced my back and that's great, but I'm having this very disconcerting pain that I did not have before surgery. And, I got an MRI. The surgeon sent it off to a specialist to confirm what he himself was seeing, but he wanted to get it from a specialist radiologist. And she came back with this diagnosis. And she diagnosed it as a mild arachnoiditis. And I think based on what I've been learning, it's better at that point to say early stage, because in the last year since my diagnosis, I've noticed that it's getting worse. But that said, I'm mobile, I socialize, I cope. And I think there's a lot of us out there who we're in the coping stage. So that's what's going on with me. And I want to turn the tables and ask you some questions, Dr. Tennant. I've heard secondhand that you have said that adhesive arachnoiditis is a silent epidemic. And I wonder if I heard right and if you still feel that way.
You're getting ahead of me. I was just getting ready to tell everybody the name of your article,
Oh, okay.
which is My Probably Not So Rare Disease. Okay.
Yeah.
I think that, and I was going to ask you why you picked this title, and indeed, that's no rumor that I've said that. I do not, based on everything I can come up with, this disease is increasing in the population, both in incidence, that means new cases, and prevalence mean number of existing cases. And I wanted to know why you gave this title. You obviously didn't think this has always been called a rare disease, but practically any doctor today who sees pain patients or just general practice has probably got some of these cases in their practice now. And so I think it's an emerging disease. And you sort of imply that here. Why did you call your article this?
Well, I think one of the things that convinced me that it's likely underdiagnosed is that, there are so many just lumbar fusions, and it's, there's a lot of us old people around and our backs are deteriorating, and very sadly I have learned there are many younger people who have back problems that require surgery, and which is entry point. It's an assault on this spinal fluid and the spinal canal. And so I kind of did some quick math and determined, if in fact there are 3 to 6% of patients, back surgery patients who have arachnoiditis, I mean, that's a huge number of people. It's like that alone. Now, I have not been able to pin down that figure, but the very kind back surgeon who I went to for a second opinion, and who, read my surgical notes and looked at my MRI and confirmed the diagnosis, he was the first one who told me that figure. And when you and I spoke on the phone, you said that sounded about right. If it's anywhere close to that, that's, tens of thousands of people. And that's just in the surgical space. It doesn't deal with epidurals, and the spinal taps and the injuries, the back injuries that people suffer. So, there's got to be a lot of us out there. And I think if I have a mission, it is to get the word out, of course, to the patient community so they know to ask doctors about this. But I really want to get it out to the medical community, to get them talking. Our doctors are so siloed. The surgeons do their thing, the pain docs do their thing, the primary docs, bless their hearts, have to deal with it all, bits and pieces. And if we can kind of get some knowledge flowing between people. I mean, it was significant to me that both my surgeon and the doctor who gave me the confirmed my diagnosis, both surgeons with busy practices, that, they're very, very well aware that arachnoiditis happens in some of their patients. I mean, they just know it. And but they don't treat it, as my pain specialist said. No, they pass them along to me, he says. I wish that the spine doctors, the neurologists, and the orthopedic docs would really lead the charge for research into this. I think it's a moral obligation. Now, that said, there are many things that can go wrong with back surgery. This is, in their world of things that can go wrong, a small piece perhaps, but I still think it's something, given the severity, the lifetime sentence that comes with this diagnosis. I do feel that they have some obligation to speak about it, to have it be a topic at their conferences, and to, as you said to me, the Harvards and the Cleveland Clinics and the Mayos, the big people, with the resources, I think should be tackling this. So anyway, those are some of my thoughts on it.
Julie, let me read. I've got your paper right here.
Okay.
I think they need to hear the data that you put in your paper. Okay, you touched upon it. You've said that in the United States, 340,000 back surgeries were done in 2023. And if just 4% of those got arachnoiditis, that adds up to 13,600 people. In other words, that's a lot of people from that. One other thing I think needs to be said, one of my mentors, a man by the name of Dr. Antonio Aldretti, believes that the biggest cause of failed back surgery syndrome, meaning the back surgeries that didn't relieve pain, were caused by adhesive arachnoiditis. And he wrote about that, and he did firmly believe that. And a lot of the old timers that preceded me, that was one of their beliefs, is that what was called, that term's not used as much as it used to be, but the term failed back surgery syndrome was primarily adhesive arachnoiditis. But what you pointed out here is some numbers that if just 4% of those 340,000 surgeries end up with arachnoiditis, no wonder we're seeing more cases all the time.
Well, and people ask me about this, did it hurt worse before or after surgery? And I said, well, I swapped one pain for another, and I'm not, I don't disparage the surgeons. They don't want to, they want happy customers, I don't think my doc did anything, untoward, but something happened, whether it was my body going into it, as you've suggested, perhaps I was prone to inflammation. Yeah, it just isn't surprising. You're in your 70s, you've got inflammation, you've got arthritis, and I'd had a cesarean, I'd had an epidural injection for pain relief that didn't help. So I'd had some previous injuries in my back. So I don't know what set me up, and I never will know. But if patients could be identified before surgery and treated, I know it's a tricky business because you need some acute inflammation to recover from the surgery. They tell us not to take anti-inflammatories before our surgery leading up to it. But if people could be identified as being prone to inflammation, then there could be, as you say, a protocol, to use your good word, in advance of a surgery, maybe to help prepare people.
Yeah, two questions. Do you think is too much surgery being done that is unnecessary or other procedures, number one? And number two, do you think the risk of arachnoiditis should be in every consent form for spinal procedures?
I was thinking about, to start with your second question, when we go into surgery, we sign something that says all these things could go wrong. I suspect, and I didn't go back and check. I'm sure one of them was, there could be nerve damage, there could be this, there could be bleeding, there could be that, but you're in pain, and multiple doctors, in my case, had told me if I didn't have my lumbar fusion and have my spinal fluid was like a black hole of death, was not flowing properly, that I would have serious health consequences, and I was in pain. So now, in the bigger, so I don't know, doctor. I don't know if it said arachnoiditis and then like, well, what's that? If that happened, then I think you'd need to start that conversation well before those papers get, but well before surgery. As to whether there are surgeries that don't need to happen, I'm sure there are. I'm also sure that here's what I surmise. I surmise that a great number of our surgeries are valuable, necessary. I feel like I've lived past my best by date, if you will, and the medical world is helping me keep going. And one of those things is repairing my back. My surgery did what it was supposed to do in terms of straightening my spine, relieving one source of pain. And I just have now a different source of pain, and it's chronic. So
another question. You said this is not a rare disorder. What term should we apply to this? This is not a moot question because, I'm very uncomfortable anymore when I say this is a rare disease because I know it's not. Do we use the term it's unusual, uncommon? How do we phrase it?
yeah, I think it would be a step in the right direction to use the word uncommon.
Uncommon.
Uncommon. I think as a word person, that's my wheelhouse. I think uncommon is a good word. And boy, wouldn't it be great if we actually knew? I mean, if we actually had some firm numbers and some good research. But, I raised this issue with my surgeon about the need for some good research into that question. And his first response was, well, they would need MRIs. Well, of course they would. They would need you'd need access to anonymized medical records, and you would need doctors and clinics willing to participate in that to start reviewing the documents. One of the complications, and I know you're well aware of this, is that often, or at least in some cases, my understanding is through research that arachnoiditis can show on an MRI, adhesive arachnoiditis, but the patients don't have the symptoms, don't have the chronic pain. So that would be another complication in research. And then it's hugely complicating that the symptoms don't show up often until down the road. And then how do you capture those patients? Because they have left the clinic of the surgeon who did this, and he or she may never have, had a conversation about this weird new pain. It may have shown up. And then you go to a pain specialist and, they may or may not review your back history at the same time they're trying to sort out what your cause of pain is. And they may not be enlightened enough to look for arachnoiditis on your MRI. Complicated, but possible. A lot of complicated research is done. And I know a lot of folks are laying some hope at the door of artificial intelligence to be able to do that kind of massive research. You still have to have access, though.
Lastly, where do we go from here?
Well, I don't know. I have two takeaway thoughts. I'm probably taking more of your time than I should as a non-expert. One of my thoughts is personally, I am trying to reach out to journalists. There are still some out there, health journalists who might tackle this. And that's a good way to start getting it out there, And I personally am using my little essay as a backgrounder, and I am going out and approaching some of the biggest health journalists in the country. So that's my personal piece, and my hope is that we can get some attention. The other thing, as a kind of a newbie to this whole conversation, unlike some of you, I think it's touchy that the conversation and the passions around opioid use have become intertwined with conversations often about arachnoiditis. And at least in my case, I will be doing my best to not use the word as I go out and try to call attention to arachnoiditis. So again, that's my approach, and some of that may be helpful in your world as well.
Yeah, I support both the things you just said, particularly the latter one, I might add. I'd like to ask if Scott Guess here and Dr. Mark Ibsen, Norm Clement, all my associates, if you got some questions here for Julie before I take up more of her time.
I am here, Dr. Tennant. I don't have any questions. I've just been listening with great interest. Always nice to have a journalist in the mix, that they're good with words.
Thank you, Scott.
Mm-hmm. Mark?
Yeah. Hi, I do have some questions. Julie, do you have a number about how much surgery we have in America versus other countries? The reason I ask you this is a common excuse for restricting opiates is this disingenuous comment that Americans use 95% of the hydrocodone on the planet. And they never mention that hydrocodone is the pain medication we produce in America, and it's not produced anywhere else. So it makes it seem like, oh, we're using lots of drugs. And I'd like to make the statement at some point, if I was informed enough, to say, well, we actually have more surgeries than everyone else on the planet. And the other thing that's part of this surgical mess that we find ourselves in is that the surgeon makes does the surgery, and 1 or 2 or 3 or as many as 6%, like you say, have a complication. There has to be a no fault in here about if you have a surgical complication, that we will treat the pain that you have instead of throwing you to the wolves or kicking you to the curb. What do you think about that?
Well, I have thought about that a lot. I think yes, I think the responsibility, for example, with my surgeon, any surgeon who does back surgery, something goes wrong. And I had a similar thing happen with a hip surgery that caused me some problems. Again, it gets to the silo. I mean, I understand that a doctor has a specialty and he probably has a heck of a time just staying on top of it, especially one as incredibly technical and skill-based as a surgeon, right? He or she can't do everything. But the obligation to that person and their clinic and the health and the insurance industry is to have pathways. The obligation of the doctor who identifies a complication is to find me, the patient, someone who can help. I shouldn't have to go out, on my own and find this person and find these people with the expertise. So that's where I find fault. I don't expect my back surgeon to be my pain specialist or my primary doc, but I expect him to coordinate. Everybody knows this.
Yeah. Well, I think that, the conundrum we have is the pain specialist is just an interventional doctor and won't treat your pain. And your primary care doctor is prohibited from treating your pain because they're afraid of going to prison. And we have several thousand doctors that have gone to prison.
Mhm.
It seems to me that it's, if Ralph Nader was an MD today, he would write unsafe at any scalpel.
Yeah, I appreciate your background, Doctor. I will say, and maybe I'm just a lucky girl, but I have not had either of those problems. My pain specialist is, we tried the interventions, and they didn't work for the technical interventions and they didn't work for me. And he is still treating my pain and trying his best with medications to treat my pain. And my family practice doc, and she got to the point where, I have Percocet. I'm not taking it, but it's there. She did prescribe it. It was the last thing she tried at, rightly so. But so maybe I've just been fortunate in that regard.
You sure have.
Yeah.
Yeah, good. Thank you. Thanks.
Yeah.
This is a great contribution. Thank you so much for writing an article without a lot of technical jargon in it that is accessible to everyone if they read it. It's a
Oh,
beautiful
thank you.
thing. Thank you.
Thank you. And I didn't answer your other question, which was, and no, I have not done any research into what's happening overseas, other than the fact that I was really intrigued that so many doctors from around the world are doing this research. They're looking, they're looking, doing these meta searches, trying to find answers to treatment for arachnoiditis, and they're coming up shorthanded all over the world. Yeah, interesting.
Yeah. Yeah.
Yeah.
Oh, one more question. Are you familiar with the book by Judy Foreman called A Nation in Pain?
No.
She wrote this in 2012 or so, and it was right at the beginning of all this nightmare. But she might be a referral for you in terms of a journalist who might want to take take it further. Medical
Thank-
journalist.
Thank
Yeah,
you so
thanks.
much. Yeah.
Okay.
Julie, we're all going to sign off for a minute. Not only want to thank you for being here and for your good article. And Jamie, I want you to have everybody, before you sign off today, tell them how to get her article. I think anybody who's interested in the disease and particularly advocacy needs to read Julie's paper, if you'll tell everyone how to obtain it. And secondly, Julie, I hope you continue your work. Certainly any data that we have that you want to incorporate into any of your writings, you're very good at it and you're very motivated. I hope you keep writing. Okay.
Thank you. Appreciate it. Thank you for what you do.
You're sure welcome. I'm so glad you're here. It's been very helpful. You will sign off for a minute. I want to bring Scott Guest back on for a moment. Scott, are you there? Yeah, I asked Scott, we got some time left, and I'd like for you and Mark to address, if you can, a little bit of our supply issues that are going on in the country. We have two issues, it seems like. One is people with legitimate prescriptions, and which everybody wants to fill them, but they can't get their medicines due to supply issues. And then, of course, we have the issues that nobody wants to help from a malicious point of view. I'd like to have Mark address that issue and update us on how we're doing in such sundry places as Maine. Anyway, Scott, can you give us a little briefing on where are we at with supply issues today for pain patients?
We're not any better off than we were 3-4 years ago. The DEA did try to make some changes to help that end of year shortage by taking the annual allocation of medications that could be made and breaking it up into quarterly sets. The only thing that did was make everybody who needed medication not be able to find it in the third month of each quarter. So we only traded one problem for another. Now, you sent me an email that had about 10 links to different medication finder websites. Unfortunately, 4 of them were error 404, doesn't exist anymore. 2 of them were just wholesaler websites, pharmacy in your search area that used that particular wholesaler. You weren't going to get any results. GoodRx is somewhat of a scam. It gets your information, it forces your pharmacy to give you a discount, and then they try and first steer you over to their mail order program. And that's not going to help you find medications because it doesn't let you know what pharmacies are either have the medication or are willing to have it. It just tries to steal your information. And the one other one that looked somewhat different was decent was something called MedFinder. And I did the research for you, everybody. Don't bother. You can do all that sign up. You can get 4 or 5 steps into it, and they want $40 per drug to search to see if somebody has your medication. And quite frankly, all the chain drugstores are under drug enforcement orders of operation where they're limited to what they can do. They're limited to what kind of medications they can purchase, how many they can purchase, and what the radius from their store, how far the patient can be away before they can even service that patient. Other things that are going on, we lost thousands of thrifty drugstores, Rite Aids, in this country this summer. When I contacted my wholesaler specifically and asked, okay, we just lost 25% of pharmacy availability in my town. Are you going to increase my allocation for controlled substances as 25% of the population now needs to find a new pharmacy? And their answer flat out was no. And that's because the wholesalers are also under the thumb of the Drug Enforcement Administration, and they just can't afford to give more medications out and get fined or lose their DEA registration and shut down a whole distribution center for 1 or 2 years. It's just prohibitively too expensive. So supply chain still is an absolute disaster, I'm afraid.
Yeah, to close out here, Mark, can we get a report from you on the lady from Maine or others that are just having a terrible time getting their drugs filled?
Yes. I do have an answer for a little side on what Scott just said. I have a couple patients who's used MedFinders, and MedFinder does have a warranty or a guarantee that if they don't find your medicine, they'll refund your money. So it's a one-time search fee, and they have found medicines for a couple of my patients. Sadly, they found a Walgreens, yes, and they wouldn't fill my prescription. So that's the story there. Brandy Stokes is just been discharged from Mass General Hospital and is looking for a pharmacy that will fill her prescriptions again. So she had a case against the New England Drug Task Force, and she's taking her information from Mass General, which basically says there's nothing more that can be done for her, and she's presenting that to the judge in her case, and hopefully they'll do an injunction. The other thing that Scott alluded to that I want everybody to be aware of is the opioid settlement injunction, which limits the amount of medications various distributors can distribute. And these distributors have skills in running trucking and conveyor belts and boxing stuff. They don't have any medical training, and they're now the gatekeeper, the second gatekeeper in the line of chokes in the supply chain. So that's got to be interrupted, and we haven't found a lawyer to take it on yet.
Well, thank you. We'll want to keep an update, particularly on Brandy Stokes. She's a real poster child for what's wrong in America. So thank you very much.
I
want to
will.
thank everybody for the show tonight. We've covered a lot of territory, and I hope we've learned a lot, and we'll carry on these discussions next week. Again, thank you so much. And Jamie, if you'll make sure everybody knows how to get Julie Titone's article. Again, thanks everybody. We'll see you next week. Good night.
Thank you so much.
Night,
Good
everybody.
night, everyone.
Good night.
Thank you.
Thank you. It was
Good night.
wonderful.
Thank you,
Did a wonderful
Julie.
job.
Thank you, Julie. Thank you,
And the
everyone.
doctors. You can find her article on Substack. That's substack.com. And you can just look up her name, JULIETITONE. And you can also type in my probably not so rare disease. And hopefully everyone can enjoy that article. We hope you have a great week and good night, and God bless everyone. Thank you
God
so
bless
much.
us, everyone.
Thank
Good night.
you. God
Good
bless
night.
everyone.
Love y'all. See you next
Love
week.
you too.
Good night, everyone.
Good night.
Good night.